Welcome to you all. I'll be discussing about the fluoroscopic anatomy for minimally invasive techniques in the management of pain of spinal origin. In the first part, I've discussed about the fluoroscopic anatomy of the lumbosacral spine. In the second part, which I'm going to record now, I'll be discussing about the fluoroscopic anatomy for minimally invasive techniques to manage pain that originates from the cervical and thoracic spine. Before that, just to introduce myself, I'm Sanjeev Gupta. I'm a consultant in pain medicine in the UK, and I've outlined my affiliation here. In addition to being a consultant in pain medicine, I also teach on the cadaver courses. I'm the director of the Leeds Interventional Pain Medicine Cadaver course and a senior instructor at the Spinal Intervention Society European courses. And I'm also a founder of the North England Pain Group, and currently I'm the elected board member of the Faculty of Pain Medicine of the Royal College of Anaesthetists. As mentioned in the part one presentation, I have written a chapter in the Atlas of Interventional Pain Management Procedures, the picture of which you can see here, a stepwise approach. I am one of the editors of the book as well, and you may wish to go through other chapters which I've written and other colleagues have written in this particular atlas. So as I said, this is the part two of the presentation, looking at the cervical and thoracic spine fluoroscopic anatomy in relation to the procedures which we commonly do at this level. That's a bigger picture of the atlas, what I mentioned. These are some guidelines, good practice guidelines published by the British Pain Society and the Faculty of Pain Medicine of the Royal College of Anaesthetists. I have shared all these three guidelines, the recommendations for good practice in the use of epidural injections for the management of pain of spinal origin in adults. And the other one is recommendations for good practice in the use of medial branch block and radiofrequency denervation for low back pain of lumbar spine origin, and also the good practice guidelines for spinal interventions. They're all available on the British Pain Society as well as the Faculty of Pain Medicine websites. You may wish to go to them. Some basic principles before we start discussing about the fluoroscopic anatomy. Understanding the neuroanatomy of the different structures that can cause spinal pain is essential before attempting any interventions. One should know which levels to block to sort of numb the joints which might be causing the pain. We can only see bony structures on fluoroscopy and have to construct a 3D image in our mind and consider the different structures in relation to the bone. This is extremely important. As I'm going to discuss later, bones are our friend and eyes, and all the soft tissue structures are in relation to the bone, and we have to construct a 3D image in our own mind. Bony anatomy and surrounding structures may not be the same in every patient, especially if they have significant spondylolysis, osteophytes, or spondylolisthesis. So we should bear this in mind when performing procedures along the spine. Bones are our friend and our eyes. Try to contact the bone before navigating the needle deeper, and this will increase the safety. I can't stress this more at the lumbar level cervical level. Cervical procedures are less forgiving, so one has to be very, very careful. Look at the bone, look at the structures where the targets are, and then look at one level above, one level below to make sure that you're blocking the right levels. And I'm going to discuss later how to eliminate the double shadows as well. So it's extremely important to land on the bone before we go any deeper. Again, to land on the bone properly, the images should be appropriate, which I will highlight during the course of this presentation. As I said already, if you're a beginner, always do at least 100 or more lumbar spine procedures before embarking onto cervical or thoracic interventions. These higher upper level interventions like cervical and thoracic are very less forgiving. If you're having difficulty in identifying the target points, look at the target points one level above and one level below. This can help to identify the target points in question. So this is extremely important, especially when there is excessive spondylolisthesis or spondylolysis, or when there is osteoporosis. And sometimes, if you can't see the target points appropriately, change the position. Like in cervical procedure, especially when I've had difficulty in identifying the target points in the lateral position, I have tried supine and sometimes even prone position to see if I can see the target points and landmarks for the target points, and then proceed the procedure. Of course, if you can't see the target points at all and you're having difficulty and not certain, cervical level, I think you should, even lumbar or thoracic level, of course, but cervical level, you should never attempt anything unless you can see the target points. And before I do any cervical procedures, I always conduct a fluoroscopic examination, make sure I can see the target points, and then only I'll scrub. And I also feel that before you start doing cervical procedures, it will be a good idea to visit one of your colleagues who does them regularly and understand exactly the neuro and the fluoroscopic anatomy before you start doing on your own. Again, basic principles. Use standardized terminology to identify the structures for the procedures being done so that you can communicate with your colleagues appropriately as to what you've done. I've already discussed about the lumbar level. Count the level from T12 down, be aware of transitional vertebra at L5S1 level. And I've also said that compare the sagittal T2 MRI image with the lateral fluoroscopic image when performing transforaminal epidural injection so that correct levels are done. Coming to cervical levels, count the vertebral levels. You need to get the levels right. So the C2 spinous process is the largest among the lot. So count down from C2 down to C3, C4, C5, C6, C7. If you're having difficulty or you want to count up from C7 upwards, then the transverse process of C7 goes down, slants down, and the transverse process of T1 slants up. That's how you can identify if it is C7 or a lower level. So the transverse process of C7 normally slants down, and then you count upwards from C7 to C6 and upwards. Patient position is also extremely important. As I said earlier in my first presentation, all lumbar procedures and sacral procedures and thoracic procedures can be done in prone position. Cervical epidural and cervical medial branch block and RF can be done in prone position. In supine position, cervical medial branch block and radiofrequency denervation, cervical nerve root block, and cervical disc procedures can be done in supine position. In lateral position, cervical medial branch block and radiofrequency denervation. In my practice, lateral position is the default position for me when I'm doing cervical medial branch block and RFs. But in case of when I do a C7 medial branch RF, then I prefer prone position for the reasons I'm going to describe later. Sitting position, never on a stool or a table. It should be on a trolley or an operating table, not on a chair or a stool, because I've had one incident when I tried to do a medial branch block when the patient was sat on a chair and the patient had a vasovagal and the patient was heavy. So it was quite difficult to lift the patient up and put on the table or a trolley. So of course, nothing happened to the patient. This was about 15 or 18 years ago. Since then, I've never done a procedure in sitting position. It's not ideal. So cervical medial branch block, radiofrequency denervation may all be done. Cervical epidural can also be done. As I said, if at all you want to do in a sitting position, do it with the patient sitting on a proper trolley or an operating table so that in case there's any problem, you can lie them supine. Block needle is also extremely important. Using a curved tip needle or a needle with a slight bent at the tip, a few millimeters is bent, can be very helpful. I normally bend the needle manually, and I bend the needle away from the hub, as in my opinion, that helps me navigate the needle to the target point. Now here there is a description of how the bending can help. This image is taken from the Spinal Interventions in Pain Management book, which was published by the Oxford University Press. I'm one of the editors, and this book accompanies our leads cadaver course. Whenever delegates attend the course, we give a copy of this book as well for them to read. Now, if you look at this particular diagram, clockwise rotation directs needle to the right. If you can see here, if you rotate the tip of the needle to the in a clockwise direction, it will direct to the right. Anti-clockwise rotation directs it to the left. You can see here, it directs to the left. So imagine that you're directing in this way and you hit a bone and you want to go past the bone, just turn it to the opposite, just turn it 180 degrees or whatever degrees you want, 10 degrees or 50 degrees or 20 degrees, so you can direct the needle. So the needle comes like this, it's going like this because it's turned to clockwise. Just turn it slightly like this to go change the direction of the needle. So you can change as any degree of angulation and direct the needle in any direction you want. What it prevents is repeated in and out of the needle to get it to the target point. So you can just navigate your needle and it goes to the target point. It becomes very easy to navigate the needle with a bent tip needle. Radiation safety standards should be followed, and agree a terminology to be used when operating fluoroscopic C-arm with the radiographer to decrease unnecessary exposure. In my clinical practice, the top end of the fluoroscopy machine will be the reference point. So in relation to that, I start with AP view, then moving the top end of the fluoroscopic machine towards the head end will be cephalic tilt, and towards the foot end will be caudal tilt. Towards the right oblique will be rotation, right oblique rotation, and left oblique rotation. Of course, the lateral will be a lateral view. So in the lateral view, again, you need to be know some concept. Like sometimes when you take a lateral view, in case you want to see a disc and the nerve root, so sort of intervertebral foramina very well. In that case, in the lateral view, sometimes it may not be visible because of changes, especially at the thoracic level where the ribs and lung air shadow, it can be difficult. So moving the C-arm in the lateral position, moving the C-arm in either direction, we call it wig-wag, can define the disc and the intervertebral foramina better and identify whether your tip is in the right place and are you at the right level as well. An appropriate fluoroscopy table is essential. Now, we will discuss the fluoroscopy of the cervical and thoracic spine. And during the course of the discussion, we'll discuss about medial branch block, including C7 in a lateral position as well as in a prone position. And third occipital nerve block also we'll discuss. And at the thoracic level, we'll discuss transforaminal epidural. The lumbar procedures I've already discussed when I discussed in my part 1 of the presentation on lumbosacral fluoroscopic anatomy. Again, general considerations. Procedures at the cervical spine level are considered more riskier than lumbar level. In a very narrow space, a lot of structures are there, so the chances of complications are higher. And as I said, at least one should do at least 100 lumbar procedures before attempting thoracic and cervical procedures to get a hang of how to navigate the needle, to understand the techniques of doing this procedure better. It is advisable to use a shorter spinal needle. I normally use a 5 centimeter long needle. The longer the needle, you're likely to drive it deeper. So shorter needles are advisable in the cervical spine procedures, and the normal needles can be used for thoracic spine procedures. Cervical procedures can be done in lateral, supine, prone, or rarely sitting position. In my practice, lateral position is the default. But if I'm doing C7 or in some occasions C6 medial branch blocks, then I use a prone position. I have used supine as well in some patients wherein I could not identify the landmarks in lateral position. If the patient has a short neck, a sitting position may be used, but as I said, not on a chair. It has to be on an operating table or a trolley so that if they have a vasovagal, they can be laid flat as soon as possible. Upper cervical procedures can be done in lateral or supine position, and prone position may be considered for lower cervical procedures. I've already discussed this. The head, neck, and chest should be appropriately positioned, extremely important, which I will discuss later as well. Fluoroscopic image of C-spine should be obtained to identify the target points before scrubbing for the procedure, and I've already discussed this as well. Generally, upper cervical procedures are done one side at a time, especially third occipital nerve block. If you do third occipital nerve block, both sides, some patients can lose the orientation of the head with the body, and it can be quite tricky. As a general rule, I prefer to do cervical procedures one side at a time, even if it is the upper or a lower cervical medial branch blocks. And clinically, when you're examining these patients, it may be important to identify. Patients sometimes say that the pain is coming from both sides, but if you carefully analyze the pain, you will be able to pick up which side is more of a problem and do that side first. And in the clinical examination and consultation and assessment, also find out where the pain starts and how it progresses. Sometimes patients will tell, normally it will start on one side, and as it gets severe, it can progress and it can spread to the opposite side. So the opposite side could be a referred pain. It's difficult to say, but something to think about. Consider the possibility of pneumothorax when performing cervical or thoracic procedures, especially the lower cervical levels. When I perform lower cervical procedures, especially C6 or C7 levels, I warn the patients about pneumothorax and I advise them not to fly in an aeroplane for around 7 days or so. This is a C-spine model. As I said, cervical spine procedures are less forgiving because lots of structures are compactly packed in very sort of a narrow space. Lateral position viewed from the back, here you can see, and this lateral position viewed from the front. The patient is lying on his side, and there's a rolled sort of a sheet there which supports the neck, or you can put a pillow as well here. So rolled sheet or a pillow, either can be possible. So the neck is there, and ask the patient to get the shoulder as low as possible. Here as well, now get the shoulder as low as possible, and then place this sort of a sheet, rolled sheet there or a pillow, and ask the patient to sort of bend the knee as close to the chest as possible, and ask them to hold the arm, hold the knees with the arm, so that you get a very sort of fetal position. That's what Dr. Sheridan calls it. Fetal position is important, so that you get the maximum length of the cervical spine on the fluoroscopic image. Lateral view from the side and from the head end of the table, and in this case we have placed a pillow. You can place a rolled sheet as well, so that the patient is comfortable as well. Lateral view of the cervical spine model with the needle tip showing the target point for C4 medial branch block, that is C2, C3, C4. This picture was supplied to me by Dr. Sheridan, who is a consultant in pain medicine in Sweden and a guru of diagnostic and therapeutic interventions along the spine. This is lateral view of the spine, cervical spine. You can see the sort of a most prominent spinous process is C2, then C3, C4, C5. Now, the reason I'm showing this particular picture is that the articular pillars are not superimposed here, and there are double shadows. You can see the double shadow here. You can see at the C3 level and the C4 level. You can see that there is a double shadow here, there is a double shadow here, there's a double shadow here, there is a double shadow here. Even the C3-2-3 facet joint are not aligned. You can see the C2-3 facet joint is not aligned. So here we don't know which one is the right side or the left side. So say, for example, if you're planning a C3 and C4 medial branch block on the right side, it will be difficult to identify which one is right and which one is left. If you get it wrong, you'll probably go through very important structures, including nerve roots and spinal cord, and that's not going to help you. So it's important to eliminate these double shadows. So for purpose of ease, I have termed these shadows, which are from the facet joints, these as horizontal or oblique shadows. Here you can see the horizontal or oblique double shadows, and the margin of the posterior margin of the articular pillar, I've termed it as vertical shadow. You can see one vertical shadow here, one vertical shadow here, one here, and one here. And how can we align? That's what I'm trying to come to. So normally in my clinical practice, what I do is I first align the vertical shadows together by right or left oblique rotation. Yeah, right or left oblique rotation. So when I'm doing this left or right oblique rotation, I'm using continuous fluoroscopy. So on continuous fluoroscopy, if I go right oblique rotation, and these two double shadows, as I said, these two double shadows here, and here, if they come closer together, then I'm going in the right direction. If they go apart, then I'm going in the opposite direction. So I need to go on the other direction. So that's how I try to align the vertical shadows first. Once the vertical shadows are aligned and they appear as a crisp line here, then I align the horizontal or the oblique shadows by cephalic or caudal tilt. Yeah, cephalic or caudal tilt under continuous fluoroscopy. So when I do that, if the double shadows, the horizontal or the oblique double shadows are coming closer, then I'm in the right direction. If they're going apart, then I have to change my direction to the opposite one. So that's how I try to align the vertical as well as oblique shadows. So I've labeled here vertical double shadow. These are the vertical double shadows here. You can see a lot of them. And then that is the horizontal, that is the oblique or the horizontal double shadow. Now in this picture, which I've borrowed from the Interventional Pain Management, a practical approach, again edited by me and my colleagues, published from India, using the right or the left oblique rotation, I have aligned the vertical shadow. That's what I call the vertical shadow here. You can see that this is a single line. And by cephalic or caudal tilt, I have aligned the horizontal or the oblique shadow here. Now you can see here the articular pillar or the articular process is appearing like a single unit, and that is a facet joint, C3 for facet joints, that is C23 facet joint. So once you align them, then identify the structures. So as I said, the biggest spinous process is from TC2, so that helps us to identify the level. And you also have to keep an eye on the superior border of the C2. Yeah, especially when you're doing a third occipital nerve block, which I will discuss later. And there should be a gap between the superior articular process, between the spinous process, and the articular process. That is the spinous process. You can see that. And that is the articular process. There should be a gap here. You can see that gap between the spinous process and the articular process. You can see a gap here as well. Yeah. And the C2 spinous process is here. The target for C3 medial branch block is at the centroid of the rhomboid. That is the rhomboid there. Yeah. Centroid of the rhomboid. And target for C4 medial branch is the centroid of the C4 articular pillar. And that is the disc space. And the pedicle should be at the superior posterior border of the intervertebral disc. That's a true lateral view where the right and the left articular pillars have been superimposed. Now, as long as you put the patient in the right position, in the sense that if you're planning the right side of the right third or fourth medial branch block, and the patient is lying in the appropriate position, you are likely to enter straight onto the landmark and inject the local anesthetic to block the medial branch. Double shadow, you can see here lots of oblique or horizontal double shadows. I'll call it oblique here. You can see the oblique shadow at C5, 6 and C6, 7 level. So for this case, a continuous fluoroscopy and cephalic tilt towards the head end, or a caudal tilt. If when you're doing cephalic tilt, the gap between the double lines are going away and more double lines are appearing, that means you're going in the wrong direction at that level. So you go in the opposite direction and align these double lines and eliminate the parallax of the double shadows. You can see in the next picture here. Look at this here. There are double shadows here. Yeah, that is C2, C3, C4, C5, C6. Yeah, there are lots of double shadows here. You can see that here as well, not crisp at all. Now, once you've done that, C2, C3, C4, C5, you can see that the double shadows have been eliminated here. So this is good for C5 medial branch block. There is still double shadow at the C6 level, so this is not appropriate for C6. You may have to do a bit more tilt, cephalic or caudal, whichever direction you feel appropriate under continuous fluoroscopy, to align the lines appropriately so that they appear as a single line. Here you can see that's nice. Here, lots of double shadows. You can see that here. I'm just impressing upon you the concept of double shadow. Again, here you can see the top end of C2. There's a double shadow here. There's a double shadow here. So this is not appropriate for C23, third occipital nerve block. Probably not well for this. It's just ideal for the C5 medial branch block. Now, I'm asking here, cervical spine, identify the double shadow or the parallax. Again, this picture was borrowed from the Spinal Interventions in Pain Management book. And you can see here, there's a double shadow at C3 level. You can see that. Yeah, that's what I call a vertical double shadow. There's a double shadow at C4 as well and C5 as well. Lots of double shadows. So to eliminate the vertical double shadows, you'll have to go right or the left oblique. So when you go right or the left oblique, if the distance between the two vertical lines here, which are the lateral margins of the articular processes, if they are coming closer, then you're in the right direction. But if the distance between them is increasing, then you're in the wrong direction. You need to just go to the opposite direction, be it the right or the left oblique rotation. That's the reason I feel it's important to examine under continuous fluoroscopy. Only that will tell us if they're coming together or going apart, and they should come together and form a single line instead of being double line like that. Yeah. So once you adjusted and corrected the oblique, the vertical double shadow, then if there are horizontal or oblique double shadows, go cephalic or caudal tilt and eliminate that as well. And then start the procedure and identify the structures of the spine. Now you see here, you can see all the double shadows. Once I've done the appropriate rotation, all the double shadows have disappeared, and you got a very good sort of a rhomboid type picture where the right and the left articular pillar is superimposed, and you can see there as well, nicely superimposed. You can see quite a pretty sort of a good picture here, and the disc spaces are very well visible. The vertebral body is well outlined, and the pedicle appears at the superior posterior border of the vertebral body, and there is a space between the articular process and the spinous process. There is a space here, there's a space here, you can see the space here as well, there's a space here as well, and C2, C3, C4, C5, you can count them very well. So understanding how to eliminate the double shadow is the most important thing if you're doing procedures at the cervical spine level. Once you have done that, then the cervical spine procedure becomes very safe and very easy to do as well. Needle is at the C5, C2, C3, C4, C5. So repeated counting and confirming that your level is right is extremely important. It's very easy to get it wrong. Yeah, the needle tip is at the ready to block the C5 medial branch. But note there are double shadows up above. You can see here there is horizontal double shadow, the vertical double shadow here at C3 level, and there is oblique double shadow at the C2, C3, C4 level. So another important point one has to understand is that you'll be able to get the double shadows off and get the right image with the superimposed right and left articular process at one level or maybe maximum 2 levels. Rarely you'll get at 3 levels. But generally what we say is at every level, you have to adjust and make sure that the double shadows are eliminated before you perform the procedure. So at every level, it'll be better to make sure that it's done at every level. Now, again, you can see the needle tip is here for C2, 3, 4, C5 medial branch block. There are oblique double shadows at C6, 7 level. So you can't do a C6 medial branch block. It's ideal for C5. For this, again, you have to go cephalic or caudal tilt, eliminate the double shadow, and then consider if the images are right before performing the procedure. This is anterior inferior oblique view. A patient in lateral position with the C-arm rotated anteriorly and with a caudal tilt. You can see that it's rotated anteriorly with a caudal tilt. This is a fluoroscopic image of the anterior inferior oblique view. This is the fluoroscopic image. The optimal view is when the opposite side pedicle appears in the middle of the vertebral body. Here you can see the vertebral body. That's the vertebral body, as you know. The pedicle should appear, the opposite pedicle, the ipsilateral pedicle is here. The opposite pedicle should appear in the middle of the vertebral body. Yeah, and the intervertebral disc should appear well defined. These projections are used when performing cervical radiofrequency, medial branch radiofrequency denervation, as described by Dr. Sheridan Nath. There is a chapter on cervical radiofrequency denervation in lateral position in the Atlas of Interventional Pain Procedures, a stepwise approach, which I mentioned earlier. Dr. Nath is the first author for that. So getting appropriate anterior inferior oblique view can help you to navigate the needle to the right level and right depth as well in such procedures. Now, as I said earlier, sometimes you will not be able to perform the procedure in lateral view because the landmarks are not visible, or if you're performing the lower cervical levels, especially C7 and sometimes C6 as well, rarely, then prone position is important. And it will be important to know how to do these procedures in multiple positions. So we've discussed thus far about doing the procedure either in lateral or supine position, but I prefer lateral, so I've chosen that. But even if you're doing in the supine position, the images are exactly the same. The orientation will be slightly different, but you'll have to superimpose the articular pillars and then do. But the other way of doing it is in prone position. Here you can see the patient is lying prone with a pillow under the chest, and the head can be supported on a wedge or something like that, yeah. And the shoulder should be pulled down onto the side, yeah, and the head is supported on a ring or a wedge, yeah. For cervical medial branch block, the neck is turned to the opposite side. Say it's turned to the opposite side so that the structures which the target points become visible. For epidural, interlaminar epidural, the chin is tucked onto the pillow, and so the fold in the lower part of the neck is removed. So once you got the AP view, identify the structures. Yeah, these are the articular pillars. You can see nicely here. Yeah, that's the articular pillar, and that is the articular pillar. This is the facet joint. Yeah, this is the facet joint. This is the facet joint. Yeah, that's the spinous process. Yeah, probably C7 spinous process. And you can see here, the most important thing what I want to show in this picture is identifying the C7 vertebral, C7 transverse process and the C7 articular pillar. You can see here, there is a curve here. Needs a bit of a experience to see this. You can see a curve here, like the sort of a front end of the ski boot. Yeah. So the C7 transverse process goes down, as I said, and the T1 comes up. The C7 goes down, slightly slants down. So that is the C7 transverse process there. And C7 articular pillar is here. Yeah. And the target for C7 medial branch block is one just at the junction of the superior articular process, superior articular process of C7 and the transverse process, and one slightly above and one slightly low below, as there is variation in the way the nerve goes there. Now, is this the optimal position image for C7 medial branch block? Not really, because the C7 medial branch block should be here. Ideally, the image should be somewhere here so that you can see the structures better. So this is not an ideal. So one of the things one has to remember is the target point should preferably at the center of the screen so that you can see one level above, one level below. That makes the procedure safer, in my opinion. This is another AP view showing the needle tip at the junction of the C7 superior articular process and the transverse process, again borrowed from this particular book. So you can see here, just about visible, the superior articular process of C7 and the transverse process of C7. That is the junction. That is the first target point. The second target point will be slightly away and slightly up above the third target point. Now, AP fluoroscopic view of cervical spine with needle tips in position for C5, C6, and the first target point for the C7 medial branch block. As I said here, you can see the transverse process of C7 and the superior articular process of C7. That's one needle there. And the deepest, the curvature of each of these lateral margins of the articular pillars, the deepest point of the curvature is the target point for the respective medial branch block, C6 medial branch block and C5 medial branch block. And again, using a curved tip needle helps quite a lot, because you can see there is a subtle curve here. If you can see that, there is a subtle curve here. You can see that. So when I'm doing this procedure, I direct the curve medially. So I hit the bone, then hit the bone like this, yeah. Then turn the needle and go past the bone, and then again turn towards the bone so that you're hugging the bone basically. So AP view of the cervical spine. The target point for the medial branch block is the most medial aspect of the waist of the respective articular pillar. This image is appropriate for left C4 medial branch block, and the arrow points at the junction of the superior articular process with the transverse process of C7, which appears like the front of a ski boot. So what I'm trying to show is the waist of the articular pillar, the most sort of a medial aspect of the waist of the articular pillar. That's C4, C5, C6, and C7. And you can see a ski boot type picture here. Yeah, the arrow is pointing at the junction of the superior articular process of C7 and the transverse process of C7. As I said, it's not easy to identify, but once you start looking for it, you will see it needs a bit of an experience. Now, moving on to third occipital nerve block. It's quite an important block. And we block this nerve in patients who are suspected to have cervicogenic headache. Nearly 54% of patients who have cervicogenic headache, the C2-3 joint is the source of the pain. And it's quite common after road traffic accident as well. So when we do a third occipital nerve block, it is pretty easy to do, but the fluoroscopic anatomy is the most important. So 3 things we have to bear in mind. This is in lateral position again, what I'm doing now. Eliminate the double shadow in the upper border of C2. So if you look at C2 here, you can see a double shadow here again. You can see that. You need to eliminate the double shadow there. Once you do that, obviously the double shadow here also will get eliminated. Yeah. The C2-3 facet joint line should appear crisp. Here it doesn't look too bad actually, but let us see if it can be made any better. And the C2-3 intervertebral foramina should be well defined. So let us look at this. There appears to be some double shadow here from what I can see. So this is the same patient. Once the to correct the double shadow at the top end of the C2, you'll have to use tilt, either cephalic or caudal tilt. Yeah, I would say that is a horizontal or oblique double shadow. So any horizontal oblique double shadow, you have to eliminate that by cephalic or caudal tilt. So that has been eliminated now. Yeah, cephalic or caudal tilt has been applied, and the double shadow, you can see the difference here and difference here. It appears like a single line. Then you try to go right or left oblique and see if you can make it more crispier. Then in that process, you will also see that the facet joint can be made more crispier as well, and the intervertebral foramina becomes much more crispier. So look at this intervertebral foramina. It's not as crispy in my opinion. And once you have aligned that, you can see it becomes very crisp. And in this, you have to identify the upper border of the superior articular process of C3 and the lower border of the C2-3 intervertebral foramina. I'll tell you why you should do that. Another image, just to show you. Again, this image appears very same patient. You can see the screws here. I'm sorry, but that's not an ideal image, as you can see. These images are, I've used some of the images here when I was performing radiofrequency denervation. You can see the needle, radiofrequency needle here. But anyway, so the image is not very clear. You can see double shadow here. You can see here, and the joint is also not crisp here. But here you can see the double shadow has been eliminated. It got eliminated automatically. This is not a C2 medial branch block I'm doing. I just wanted to show the double shadow at the top end. Probably it's better visible in this particular picture. So this image shows a lateral view of the cervical spine at the C2, C3 level. And I can also show imaginary line bisecting the C2-3 facet joints. You can see this line here, imaginary line bisecting the C2-3 facet joint line. And the 3 target points that are used to block the third occipital nerve, the 3 target points lie on an axial line that bisects the C2 and C3 articular pillars. You can see the articular pillar of C2 and C3 and the facet joint here, C2-3 facet joint. So the 3 target points to block the third occipital nerve lies on the axial line that bisects the C2 and C3 articular pillars. The 3 target points lie at the intersection of the axial line, axial line here, and the transverse lines through the apex of the C3 articular process. You can see C3 articular process through the apex of the C3 articular process. The second one is tangent to the bottom of the C2-3 intervertebral foramina. You can see the bottom of the intervertebral foramina here. That is the second line. And the third one is between the 2 at the level of the facet joint. So 3 target points to block the third occipital nerve. The top end is in line with the top end of the C3 articular process. And the bottom one is at the bottom of the C2-3 intervertebral foramina. And the middle one is at the joint line level, at the C2-3 facet joint level, or in the middle of the first 2, the top and the bottom line. So you inject about 0.3 ml of local anesthetic at each of these 3 target points, and that will block the third occipital nerve. Third occipital nerve is bigger than all the other medial branches, and the reason we block 3 different areas is to cover the variability of the course of this third occipital nerve. Now here you can see that is the first target point, and the second, that is the third. Actually, this at the joint level, that is the target point of the joint level, and that is the third target point. So when you're injecting the joint level, just be careful. Don't go into the joint or go through the joint. That might not be safe. Now, when you're doing cervical facet medial branch blocks, we need to decide which levels to do and how to progress. On clinical examination using pain maps, which again, in the same book, I've written a chapter on cervical medial branch block as well. You might wish to go and see that chapter. It's quite a good chapter in my opinion. And these algorithms are there as well. The most common joints involved C5, 6 is the most common, followed by C6, 7, C4, 5, and C7, T1. So select the most common joint. What I find in practice is the C4, 5, and C5, 6 joints are very commonly involved. And when you perform the procedure, ask the patient to keep a note of their pain before the procedure, at rest, as well as on movements in different direction. Then once the procedure is done, come and assess the patient again before they're discharged and ask them to do all the movements which caused pain and find out if the pain is significantly better than what it was before the procedure. That will help us to find out if the pain is originating from those blocked facet joints. Now, there is a high false positive rate of nearly 27%. So normally it's advised that a confirmatory block should be performed. Then again, this adds to the cost of the procedure. So in the NHS, we perform one block, and if that is positive, we go ahead and block. We go on to do the radiofrequency denervation. If the patient doesn't get good pain relief with the initial chosen joints, then look if there are other joints which might be causing the pain. As I said, cervicogenic headache, C2-3 joint, 54% of patients who have cervicogenic headache, which is pain in the neck, starts in the neck, and as it gets severe, it can go into the head and bother. So if patients complain of upper cervical spine, upper neck pain going into the head, it's more likely to be C2-3, maybe C3-4 as well, or the higher joint, C1-2 or C0-C1. If they're complaining of pain in the middle or lower part of the neck, going between the shoulder blades or the suprascapular area, or even up to the upper arm area, but this is a referred pain, then it's more likely to be the lower neck pain or middle neck pain. As I said, the previous one, the lower facet joint, C5-6 is the most commonest. So this is the algorithm for middle and lower neck pain, and this is the algorithm for upper neck pain, which I have sort of put together. So if you perform C2-3 joint block and the patient gets good pain relief, and technical adequate means they should have a numbness in the occipital area. That's where part of the supply of the third occipital now goes through. So if they have good pain, numbness there, that's the right block. And if they get good pain relief and they have numbness in that area, then the block also has been adequate, and it's likely to be coming from the C2-3 joints. But please do look at the cervical medial branch block chapter that will describe in greater detail. Moving on to the thoracic fluoroscopy, this is an AP view in prone position. Keep a pillow for comfort. The upper limb should be higher up so that in case you need a lateral view, the upper limb doesn't come in the way. This is an image from the front end of the table. Here I've shown caudal tilt and cephalic tilt. What I mean to say with cephalic and caudal tilt, that's what this picture shows. Here I've shown C-arm rotated to the right and the left. I'm sure you know this. In the lateral view, it's important, especially at the thoracic spine level where there are ribs and the lung shadow is there. You may be lucky to get and see a true lateral view immediately. So you may need a bit of a wig-wag, as I said earlier, moving the C-arm in this direction or in this direction, in this direction or in this direction to square the intervertebral discs, and that will improve the visibility of the intervertebral foramina. So that's the most important thing. If you're unable to see the intervertebral foramina when you're performing the transforaminal epidural, then using a wig-wag of the C-arm, moving the C-arm in either this direction, I mean to say this is not the whole C-arm, just tilting in either direction can make the discs visible more crisply and show up the intervertebral foramina. Thoracic fluoroscopy again. Once you get a true AP view in the thoracic fluoroscopy, as I said in the lumbar fluoroscopy as well, obtain an AP view. Yeah, in the true AP view, the pedicles, the two pedicles, the spinous process will be in the center of the two pedicles, and then go cephalic or caudal tilt to square the intervertebral disc. So this is a sort of a sequential fluoroscopy, what I call. So true AP view is where the spinous process is in the center of the two pedicles. Then cephalic or caudal tilt, it depends upon which level you are, will square the vertebral disc. Yeah. At that point, identify the structures. You can see the pedicle here, spinous process in the center, spinous process here, pedicle here, and intervertebral disc and the vertebral end plates have been squared off. Yeah, you can see that very well. And right oblique view showing a transforaminal epidural being performed. The arrow points to the end-on view of the needle when performing the transforaminal epidural. So if you can look at this particular needle here, I'm trying to do a transforaminal epidural. Of course, it is much lower than the pedicle area. That's fine. So I'm trying to do a transforaminal block in this case, and try to identify the structure at every point. Yeah, you can see the rib here. You can see the rib, middle end of the rib, and I'm trying to do the transforaminal here. And this gives the direction of the needle only, not the depth. And in this image, you can see that's the vertebral body, that's the pedicle, yeah, and the needle tip is here. But the discs are not very crisp here. So in this image, you can see the disc is much crispier by wigwag, and that's intervertebral foramina. That is the intervertebral foramina. The needle tip can be seen here. Yeah, as I said, it was not subpedicular, so you can see the needle tip here, and the vertebral end plates can also be seen here. Yeah. This is one of the books we had published, which might give some theoretical aspects of what we do in pain management. And this is another book, Practical Management of Complex Cancer Pain, which we edited and published by the Oxford University Press. If anybody is doing cancer pain management procedures or managing cancer pain, this book can be very helpful. So in summary, basic principles are short block needle, extremely important. I use 5 centimeter long needle, less chance of navigating needle deeper. Patient position is also important. Learn to do the procedure, same procedure in more than one positions in case you're having difficulty or the patient has a difficulty in lying in that particular position. Understand the fluoroscopic anatomy in every projection. Use continuous fluoroscopy at the cervical levels to eliminate the parallax. I know we'll be increasing the radiation when you're doing so, but imagine having a complication which can be quite serious. Compared to that, I think using continuous fluoroscopy to eliminate the double shadow or the parallax is extremely important at the cervical spine level. Cervical spine procedures are less forgiving. Start with interventions in the lumbosacral spine and then progress to cervical and thoracic areas. Bone is your friend and your eye. So when doing any procedure, land on the bone, especially if you're not using a gun barrel technique, like in patients when we do radiofrequency denervation of the cervical medial branches in lateral position or even in supine position. My default position is lateral position, as I said. Don't go too deep before contacting the bone. Contact the bone first. Go in a graded fashion, go deeper slowly, contact the bone, and then only navigate further to get the right image. The C arm may need to be moved in either direction in lateral view, especially at thoracic spine level. Wig-wag, as I said, that's also important. And another important thing is save the images, because if tomorrow there is any complication or the patient sort of has any problem, you can reflect back on your images and see if anything went wrong, or at least you can defend yourself saying that you've done everything right. So thank you very much for your attention. As I said, this accompanies the part 1 of the presentation, which covers the lumbosacral spine. And if you wish to, you can look at the book Atlas of Interventional Pain Management Procedures, a stepwise approach. I have discussed the fluoroscopic anatomy very well in that book as well. Thank you very much.